Go ahead and get started. Thanks for everyone for joining us. Um, let's start the way we do every club meeting with the four-way test. Andy, I'm waiting on you.
Sorry, I don't have it ready.
We can do it without if you don't have it ready.
Hold.
All right.
Less than 10 seconds. Maybe. There it is.
I'm glad you were on your game last week.
Yeah, right? Oh, sorry. Braden's the host. I can't screen share.
Oh, all right. Never mind. We'll just do it. Everybody on this call should know it. So let's do the four-way test. Are the things we think, say, or do. First, is it the truth? Second, fair, all
concerned.
Third,
Goodwill and better friendships.
fourth,
Will it be beneficial to all concerned.
Today's invocation is by Les. Take it away, Les.
You're muted, Les.
There we go. Sorry. God of all that is created, we give you thanks again for the opportunities to serve our neighbors in our community, our neighbors around the world, and we ask that you guide and direct us in our workplaces and in our homes. You have promised to be near us in our times of trouble and need, and quite frankly, these are times that we must trust you for each and every day. And for these days, we give you thanks. We look to you as well as our brothers and sisters here to help us to find peace and comfort and experience the presence of your Spirit. Give us strength for this day and renew us for your service. Amen.
Thanks, Les. Appreciate that.
Mm-hmm.
Family of Rotary announcements. I don't see him on the call, but congratulations to Brian Scholl. His daughter got married this past weekend. So I don't know if it was a Zoom wedding or not, but if you see Brian, say congratulations. Other announcements, just wanted to thank everybody for last week for the candidate forum that we had. We had a great turnout. We had almost 90 participants between Rotarians, visiting Rotarians, and guests. So it was a great success. It was a new way for us to lead and serve our community by hosting that. That was the first debate style event those candidates had. So that was pretty cool. There was a great article in the DNR about it. And I believe we recorded it. So if you didn't get it, or if you want to share it with somebody, let me or Braden or Andy know, and we will get you the link. Also, just a reminder, we're going to be weekly meetings through October 12th. I did talk to Dee Dee, and we're trying to do something in person now that the weather would lend itself to doing something outside. So we are hopeful for that, either the end of September or very beginning of October. Any other announcements or family Rotary announcements? Anything anybody wants to say for the benefit of the greater group? All right. Well, thanks everybody for being here. We have a great program. I'm going to turn it over to Alisa, who will introduce our speaker.
Thank you. Thank you. All right. Well, today I get to introduce my boss, which is awfully fun. Summer's background is in work with the Rural Health Policy Advocate with VCU's University Centers for Excellence in Developmental Disabilities. She's also worked with a partnership for people with disabilities, the Center for Family Involvement, and the Family to Family Network. She is a 2013 Partner in Policymaking graduate. She currently serves with the Virginia Board of People with Disabilities, the Virginia Rural Health Association. Please help me welcome Executive Director of the Harrisonburg-Rockingham Free Clinic and my boss, Summer Sage.
Alisa, thank you so much. You know, we definitely are a big team here at the Free Clinic. So I appreciate you sharing my background, but at the same time, it takes all of us to kind of pull together to bring healthcare to our community here. So I figured that at this point in COVID season, we are probably PowerPointed out and to some extent on Zoom burnout. So I wanted to make this kind of fun and interactive. So you're going to have to participate with me. And I know that Rotary tends to be a good group to do that with. So I want everyone to think about, before COVID hit, the last time you went to the doctors. Did you go because it was a routine visit where you were just doing preventative care, like your 3-month follow-up? Or did you go because you were sick? More often than not, I'm hearing from people that they go to the doctor's office when they're sick. We don't go to the doctor's office when we're healthy, right? And that's kind of the basis for what I wanted to talk about the work that we do at the Free Clinic. It's important to remember the mindset of our patient base and how we think about accessing healthcare. So the biggest piece to accessing healthcare is understanding how the patient sees the role that healthcare plays in their lives. And for the patients at the Free Clinic, they're coming to us having not received healthcare for quite some time, or not having the means to make changes in their lifestyle to embrace ongoing long-term health. So a lot of what we're doing here is we're looking at what are those barriers between the patient and the care that the Free Clinic is putting into place for them. You know, we can send a patient home and say, we need you to make these diet changes. Healthy, fresh vegetables on a regular basis, clean, lean meats. And it's not financially feasible for them to make those changes in their grocery bill. I don't know about you, but you know, we try to do healthy, fresh vegetables at my house, and my grocery bill feels like it's through the roof. I have to budget for it weekly in order to make those things happen. So it's just kind of a picture I want you to hold in your mind is when you think about healthcare and you think about going to the doctors, you go when you're sick, and then you take the advice of your doctor and you go home and you apply it. But what are the barriers that are in the place between you going to that visit and then you being able to take that information and apply it? So there are 4 A's that I want to share with you about healthcare. And we always say, is it available? Is it accessible? Is it affordable? And what's the acceptability of it? So when we talk about the access of healthcare, let's start there. It's provider. Do we have enough providers to meet the needs of the patients in the community? And I think that's what's really affecting nationwide, our primary care industry, but let's just talk specifically here in Harrisonburg. How long are our wait visits? How long does it take for us to get into a provider visit and then to have that follow-up care? For a patient that is taking time off work and is only coming to the doctors because they just realized they're sick and they need this ongoing help, they haven't planned their visits in. They haven't flexibility in their work schedule that they can say, I can come back in 3 weeks and know that I can be here at this time. So those are some of the barriers we're trying to overcome with looking at when we're open, when we're accessible to our patients, and how they go about receiving that care. How quickly can we get them in? So we try to have that availability in our appointment schedule because we normally have people that call today and want to be seen today. And it's the difficulty of getting them in as quickly as possible, but also meeting their needs when we get there, to have that moment with them to say, okay, you're coming to us with this immediate need of healthcare concern. Let's say it's an infection in their foot. But while the doctor or the nurse practitioner is assessing them, they're also saying, this person has high blood pressure and it's going untreated. This person is at risk for diabetes. Now the patient came in because they're worried about their foot, but we're also trying to meet some of those other healthcare needs. But we have to plan that over multiple visits. So now we're talking about availability and accessibility. Can the patient access it? and what's the availability of their schedule, and what's the availability of our provider schedule. So you just heard me say that sometimes a patient will come in with an immediate need, but the provider will notice 3 other healthcare concerns that they want to meet and to address. They're not going to get through to that patient whose immediate concern is, how do I get back to work? I've got 30 minutes on my lunch break to come in and see you. I want this immediate thing treated. So they're building rapport and relationship with the patient. And they're saying, okay, let's beat your foot, but let's have you come back in 2 weeks and let's have a conversation about your blood pressure. Well, why? What is it going to do? I need to work. I have to do this. And so you begin to build that relationship, and the provider can say, well, maybe we can't do anything right now, but let's at least learn more about where you are. Tell me more about your lifestyle. What's going on at home? So our provider at the free clinic and our provider in many primary care settings becomes counselor, a social determinants of health counselor with their patient. They're not just assessing that need and saying, here's your prescription, here's your health plan, go home and make these changes. They're saying, can they make these changes? Do they have a lifestyle that if I tell them you need to go on a vegan diet, they're going to say, yeah, well, that's not working, and I'm walking out because I can't afford it, or I don't know what that means, or I don't know how to adapt my lifestyle to that. So all of these things are taking place in our patient appointments now. And they need to take place over a period of time. So that affects the way we provide healthcare. And it goes again to the provider shortage issue. So we've got a provider who's trying to meet the needs and demand for more patients than they can safely carry and see. They're trying to look at the affability of the care that they're giving, because they don't want to provide information to a patient that they can't apply, because that doesn't affect their healthcare. So then we look at healthcare systems and we say, the last time I went to the doctor's, I was lucky if I got 15 minutes of FaceTime with my provider, because so much was going through and so much was in demand for insurance rates and the cost and overhead for a private practice to have a payer mix. We don't have that at the free clinic. And that is probably one of the most unique and important features of the free clinic, is that because we're not trying to meet all these insurance demands, because we're not concerned about the number of patients we see in a given time period, because we're trying to understand where our patient is at and take the time to be that listener, understand what their lifestyle is, and build relationship over multiple visits, we're able to make a greater impact in their healthcare and get them on the road to health, so that when they get that job, provides health insurance, they're able to go into a patient visit that's only 15 minutes long and keep and maintain health, instead of trying to come from so far back where it's the first visit they've made to the doctors in a few years. And they've had the time to build rapport and relationship, to learn about their healthcare, to learn about how good health changes their quality of life and their ability to be active participants in the community. So the other piece of that the free clinic does is we do a lot of education with our patients on nutrition, on medical equipment, how to use it, how to take it home and care for it, how to apply for financial assistance if we have to send them to one of the larger hospitals. I don't know if you've ever filled out a financial assistance application for a healthcare facility. I recently helped a couple family members do it. And it feels like you are purchasing a home with the amount of paperwork and the amount of documentation that they need and the legalese that you're trying to jump through and figure out. It's not a simple process. And I keep thinking, if it was difficult for us to do it, a patient who is afraid because this is the first time they've been to the doctors, maybe they just got news that they have a health issue that needs surgery, which is going to be a huge cost. And so now they're trying to fill out this application and they don't even speak English, or they don't speak it very well. It's a terrifying situation to be in. So we do a lot of work talking our patients through that, showing them the paperwork and the process, and trying to empower them to become active participants in their healthcare. So the other piece we've mentioned is patient language barriers. So we've talked about the patient coming to the clinic, how the clinic provider meets the patient where they're at, education barriers that the clinic works with, and now we want to talk about language barriers. So there's over 54 languages spoken in community here, which is amazing that we are such an interesting melting pot of cultures, and how exciting that we have a community that's growing up and learning from each other of all of these different cultures. But we haven't caught up quite in the medical world in how to meet some of these needs. When we talk about translating medical information, difficult. How do you translate something like chemotherapy? We know the word. We might even have a word for it in another language, but how do you explain to someone who's never experienced what this process is? And if you don't have knowledge in medical translation services, you might try and explain it in a way that can be very upsetting for the patient. I use chemotherapy because I actually worked with a family that had to undergo chemotherapy, and the translator was a family member and was having difficulty finding a word to explain this. And they said that essentially it was putting fire into your veins, which I think is a pretty accurate description of chemotherapy, but not one that makes a patient say, yeah, let's do that. Let's do that. And that's a cute thing that we have done here at the clinic that I'm really excited about. And we were just getting it underway when COVID hit. But there's the Bridging the Gap group at IIHS through JMU that does training for medical translation services. And we kind of partnered with them and said, hey, we need these services in different languages, everything from Spanish, Russian, Arabic, Urdu. How can we grow this base? And we're not the only ones that need it. It's in high demand in all of our healthcare facilities here in the community. So we figured if we could sponsor cost for an individual to go through that training and then have them agree to come back and volunteer those services with us over a period of 6 months to a year, that we would have provided trained, skilled medical translation individual into our community. So we would have helped grow one of those access barriers, or reduced one of those access barriers, and we'd benefit from their work clinic as well, and hope that they would continue to volunteer with us as we went on. And we had 2 people signed up going through that process as COVID started, and so we were really excited to see that there was a lot of interest in that. We also partnered with AT&T here locally about 2 years ago, and they were able to give us a donation that went towards our language service line, which is 82 cents a minute. So when you think about those visits and how that provider is wanting to build that rapport and that relationship, we have the luxury here at the clinic of not doing 15-minute visits. You have 30 minutes to an hour with your provider. But if you're doing it with a translation service, sometimes it's 82 cents a minute on top of that. So that's kind of painting the picture from the barriers that we're trying to go through, meeting the patient where they're at, trying to get them in the door so that they feel comfortable and safe, trying to provide time for that provider to determine those social determinants of health, figure out where their patient is and how do I meet their immediate need, as well as build rapport so that they continue to come back and get their health on track. How do I help the patient navigate the insurance and financial aid and Medicaid paperwork that is so complicated out there? And then how do we ensure that language is not a barrier to understanding and interpreting and implementing those healthcare plans that our providers have put in place? So that's an amazing thing that this clinic does. And the key thing that I want to share with everyone here today is that we have been blessed for over 30 years to do this with the work of volunteer providers in our community. Nurses, doctors, specialists, nurse practitioners, pharmacists, lab techs, front desk people. When COVID hit, we sat down as a team and we said, these providers are in the high-risk demographic of COVID. And they have provided care for our community, for their careers, and then beyond. And it's now time for us to take care of them. And we ask that they stay home and stay safe so that they could continue to provide care when this world settles itself. That did hurt our ability to provide as many patient visits as there is demand for. So we have a part-time staff nurse practitioner, and then we are blessed to have a couple volunteers that are still coming in that are not as in the high risk demographic and are able to continue to provide services. But we're currently operating 3 days a week and booking with 2 providers, and we're pretty much booked on a regular basis with those unless we have a no-show. Fridays are always kind of, we're never sure, you know, you have to decide if you're sick enough to come in on a Friday. But you know, I think that's been the hardest piece for us as a clinic, to continue to make those shifts, to tell our patients to be safe, tell them how to appropriately use masks, but not be afraid to come in when they need help, when they need health care, when they need meds, when they need to just touch base with their provider. So I said I wanted to make this interactive. And the big thing I wanted to ask you guys is, one, if you have any questions, I'm willing to answer them. But one of the other things that I think is a key piece to what we do here at this clinic is medication management. And so I wanted to ask you if you remember, and anyone can put it in the chat box, I'll try and catch it, but do you remember the dosage? So how much, the number of prescriptions, and the names and what they're all for, any prescriptions that you take? Could you answer those 4 questions? If you think you could answer them, just wave your hand at me. If you think you could tell me, I know the total dosage amount, I know how often I'm supposed to take them, I know what they are, and I know what they're for. All right, got a couple of people. I got some I don't see faces, so they may be right on board too. Okay, how many of you know what the dosage of cough syrup is for your child off the top of your head? All right. Normally I get more hands on that one. All right, Clinton, you say you think you know that one. Okay. We tend to know that between our kids' age, 5 milligrams to 10 milligrams, because the cup only has 2 measurements. So if you're at this age or that age. Do you think it's interesting when I do these conversations, I tend to have a little test when it comes to meds to see how people can understand how to take them and understand the medication prescription information. That stuff's not always easy. I mean, I know recently I had to go on a med. They said you need to take a total of twice a day, 2 pills twice a day, but you have to work up to it. So we want you to take 1 pill twice a day for a week, then 2 pills in the morning and 1 at night. And like there was this whole series, and I was like, wait a minute, I got to write this down because I can't keep track of it. And we do have a pharmacy and a pharmacy tech here that helps go over that information with patients. And there have been a couple of times where we've had patients come in and the providers pulled me in back and said, I just want you to see this tabletop is covered with all of the meds that they take, that they just put into a bag and brought to us and said, I don't know what I'm supposed to do with all of these as the patient. Can you help me figure out? Because they were given prescriptions over different periods of time. And maybe they went to 2 different places. I think that's another key piece to this care, is that you might have somebody who has had health insurance, then lost health insurance, and come to the free clinic, but they still have prescriptions and health plan from another provider in the area that we're trying to get information from and kind of have continuity in that plan. I know I had a patient come up to the front desk when I was up there, and they said they had been working, were offered a job that had insurance, so they had just started that. They were within the 30-day time period before their benefits were going to hit when COVID happened, and they started letting people go. So this individual no longer had health insurance from the prior job, wasn't at the current one long enough to get it, and didn't have it set up yet whether they knew if they could get Medicaid or not. And so here they were stuck in this kind of in-between place, and we were able to step in and help them out. So when I ask about what are your questions for the clinic? If there are any that you have, I can't quite see. I guess the chat box is available if we need it, but are there questions that you have about the clinic or?
Yeah, Summer, I thank you so much for being with us here today and talking a little bit about all of the services that the free clinic does for our community. Several folks have submitted questions to me personally, so
Great.
I'll talk verbally about those for you. The first question is, on an average day, how many patients does the free clinic see?
So we have an agreement with our providers that we book up to 6 patients per provider per clinic, depending on whether those are follow-up 30-minute visits or they are health history 1-hour appointments. So it would be anywhere, because you can do 3 1-hour health histories, or you can do 2 patients in each of those. It can be 3 to 6 patients per provider per clinic. And it's not a full day clinic, it's a half day clinic. Mondays are half day, so are Wednesday, and so are Friday. And we have Wednesday evening.
Yeah. And has the free clinic been providing COVID tests and do you plan to, what is the criteria for who gets a test, if so?
Sure. So that's been a real complication for us. We received tests from the State Department of Health. The way in which we had to prepare ourselves to give those tests, we had to have some special reverse air rooms. We needed fit testing for the N95 masks. You can't just wear any, you're supposed to be fit tested for them. So our clinical services director went through fit testing, tested our providers on the masks that we had. And then we were able to come up with protocol and we could provide the tests. Difficulty was we couldn't process the tests, so they were going to need to go back to the Department of Health, and our local Department of Health didn't really have a system that they could work with us to pick up those tests, and we were in the process of trying to come up with that. We are still trying to figure it out. However, we went to the hospital and said, you work with us, and they said yes. So they've provided us tests. We're able to give them. We're only testing symptomatic, so we're trying to help patients that we currently have know whether they have it or not, so that they know whether they're safe to go to work. And then we're trying to provide return to work notes for those that did test positive. Annual budget of the free clinic is about $1 million is our overall operating budget. Yes, we have suffered with the pandemic. I'm answering the question in the group chat. The main thing that's hit us hard is that our donors are 100% behind us. But I've received multiple calls from donors saying, hey, we know that everyone is in great need right now, and so we're trying to either spread it over more nonprofits, and so the amount has gone down a little bit, or they've said we're really focusing on this area of nonprofit mission-centric work, and so it might not have been be our area. The other part that's really hit us is overall state and city and county funding was down. Well, county funding was not, but city funding was down.
That's actually a secondary question that came in too, Summer. What percent has come from city or county services for the free clinic?
So 80% of our budget comes from donations that are made up of city, county, state, and then individual donors. And I don't know the percentage off the top of my head, but I can tell you that the hospital was a reduced amount. The city was a reduced amount. They are trying to kind of talk with us to see if they're able to do anything with the CARES Act funding that they received. So we've been appreciative to be a part of that conversation. Let's see, I said city, county, and then our state association amount as well is reduced.
There are a couple questions about your services, and then I'll touch on Bob's question, as well as strategic future plans for the free clinic. So I'll curate them that way. Going back to COVID, several people asked about telehealth opportunities. or is access to internet another barrier that the free clinic needs to overcome or help to overcome?
So we did go into telehealth, and the barriers for us when it came to telehealth were that we had a new electronic health record system, Athena, that many of our volunteer providers were learning and using and utilizing a lot of staff support and scribes in order to accomplish that. So when we met with our clinical medical team, they really felt like it was going to be difficult for quality measures if we tried to do telehealth with volunteer providers because they didn't have that support there. Also still required that the patient come to the clinic so that we could do labs, meds, and some of those other things. So what we ended up doing was working with two providers. We actually had about 2 JMU volunteer providers, 1 community provider, and then our staff nurse practitioner doing phone visits. Because again, the technology is something to overcome for our patient. A lot of them can do a FaceTime, but to go through a telehealth service, it was difficult. And then to add the language line on top of it was causing just some complications in communicating directly with the patient. They did telephone, which is still telehealth, but kind of removing some of that technological difficulty for the patient as well as for the provider. And we're able to do those for a time period during the height of our kind of COVID numbers. And we were going down to only the visits we had to do in person. And so now we're trying to balance people in person versus telephone visits that we can do. What was the other part of that question? I'm sorry, telehealth.
Just telehealth. Oh, and barrier to technology, but you touched on that.
Yeah.
And I'll circle back to Bob's question. You touched on your volunteers during COVID, but could talk a little bit about longstanding providers that provide their time, volunteer their time for the free clinic.
So we do. We are based off of utilizing volunteer providers. Some have been here since the clinic started, but currently we only have our volunteer medical director and then our JMU 2 nurse practitioners and our staff nurse practitioner that are providers coming in. We have specialists that are coming in on Wednesday evenings that are still providing volunteer services. They run kind of a gamut, but they come in on those Wednesday evenings, and the staff have set up kind of the clinic for them so they can come in, touch base, and meet with the patients that the clinic sees on a regular ongoing basis.
Several of us are aware that there's a mental health component to the free clinic as well. Talk a little bit about that, particularly as places see rises in the need for mental health as relates to COVID-19.
So behavioral health and mental health have been the biggest challenge for us at the free clinic. We talked about the barrier of language in primary care. Well, the barrier of language in counseling or in mental health counseling is huge. And bringing in a third-party medical translation person for 82 cents a minute for a very emotional or intimate behavioral health setting is difficult. You don't want that third person in the room sharing your information, especially when they're just a voice coming in on an iPad for the most part. We have a high need for Spanish counselors in this community. And we also are working against a lot of cultural stigma when it comes to accessing behavioral health services. So we are very blessed to be working with EMU at this time, and we do have one behavioral health counselor who is bilingual in Spanish, and she is booked, but does a beautiful job working with our patients. But that is an area that we see a growing need for. Difficulty is getting the patient to, again, come to the table when it comes to that healthcare plan. So it's building that rapport as your provider with the patient in order to get them to a place of comfort to coming to those behavioral health visits. And then once you do, having that language not be a barrier. So needing people that are bilingual in the behavioral health arena is a huge piece for us.
Thanks for that, Summer. You talked about helping clients, patients handle their prescriptions. Do you ever see the bag of prescriptions that you described putting on the table? Do you see or do you serve folks that may be addicted to medical prescriptions? And how does the free clinic handle that?
Substance abuse disorder is a huge issue in community. And I think it's one that we're still trying to wrap our head around in the Harrisonburg-Rockingham community, because it's still kind of like a where do they go for ongoing care? So we don't have a substance use program here. We do work well with patients that are going through programs in the community, or we're trying to refer them into programs in the community. So yes, do we come across patients that are addicted? We do. We don't tend to see them at the height of the addiction. We tend to see them as they're trying to get on that pathway to health and are trying to put the supports in place. And for the most part, it's just because we don't have the training or the capacity to undertake that kind of intense program. So we're trying to connect them with the services in this community that we can, which we need more of those services. And those are directly linked to mental health services as well. And that's that integrated care model, where if we could, in a perfect world, have it set up that you come in and you see your primary care provider and you meet with them and you get your meds reconciled, you get your health care plan in place, and that provider knows that you're now going to the next door or the next room and meeting with that mental health counselor to follow up on how was your visit, how are things going, how are the meds, are you understanding, to then go on to maybe class or a workshop or work group that helps you better understand how to maintain that healthcare plan. That would be ideal. And it's something we've talked about a lot here. It's how do we do that? And how do we find the resources and the people to provide those services as well?
Yeah, that's something that our club has been presented to the last couple of months. Strength and Peers came to talk to us about substance abuse and how they handle and counsel their clients through that. But speaking of the different nonprofits and organizations that you partner with, talk a little bit about others, other partnerships that you have with community organizations.
Sure. So we do a lot of work with JMU and EMU. Like I said, EMU has the nursing program that comes through and helps, and our behavioral health counseling. We work with JMU through the PA program. We have health service administration interns that come in and help with the front desk. In fact, our interns right now and our students have been a real resource to us during pandemic, because they're kind of in a demographic that's not as high risk, and they're able to come in and provide some of those services that our long-term volunteers had been doing. We work with United Way, and we did a lot of our expansion research based off of their ALICE report. So some of the things that the clinic had done prior to this pandemic world were to expand our services to include those in the ALICE population. So we wanted to catch those who needed a survival budget. We raised our eligibility guidelines to 300% of the federal poverty level. We also, based on those demographic pieces, saw that we talked about how culturally diverse this community is, and requiring citizenship status as a barrier to care was kind of cutting out a very large part of the population here. And so the board did make a decision to expand to provide care regardless of citizenship status. We don't track it, but it's not something that is a requirement in our eligibility documents. The hospital, sorry, my coffee's kicking in. The hospital is a big supporter of us, and in many ways they do a lot of our lab processing. They work with us on prescription assistance costs, a lot of the just supplies, gowns, gloves, some of our PPE and cleaning supplies and equipment come from the hospital. We also work with Direct Relief and RX Partnership. So those are two things. We know the cost of prescriptions are just astronomical. So anytime we can have a partnership with an organization that can provide those at low to no cost is key for our patients. We work with the Lions Club. They help with glasses and vision screenings. We have a lot of specialists in the community that we've worked with. We've worked with dentists in the area that have provided services for our patients. And we are supported by quite a few churches. And when the pandemic hit and we had patients that desperately needed masks and mask protocol, we were able to work with the Mennonite Relief Association, and they provided us 3,000 masks overnight.
Wow.
And that was incredible. And we were able to then work with some students in the community as well to translate mask protocol into Arabic, Swahili, Russian, English, Spanish, and then hand those out as well. We were able to go to some of the county and city testing sites and hand those out too. It's great.
That's really fabulous work. It's a community-wide service, which I really appreciate, Summer. Speaking of your partnership with RMH, Centera RMH, Mal has a question about how lab tests work in the chat here. Are they processed by the hospital? And he gives the example of blood tests.
Yeah. So other than some very beginning point of care testing, urine tests, things like that, everything gets sent to the hospital and the hospital processes them for us.
Thanks for that. And Quentin asks, is transportation an issue for some patients? How does the free clinic address that?
So transportation is probably the biggest issue for our county residents, and it's something that we've talked about at the board level a couple of times. And when you talk about strategic planning, it's a major issue for county residents to try and figure out how to get out and reach them and get them to the clinic. We do things through our Bernie's Purse where we can provide gas cards. I know JMU has donated gas cards as well. Under a couple of circumstances when it's been really difficult and we absolutely have to get this patient where they need to be, we pulled from Bernie's Purse to pay for like an Uber or a Lyft to get them there, and different things like that. But yeah, it's a key piece to healthcare. It's another one of those barriers, one of those social determinants of health is not, especially in today's day and age, not just do they have transportation, but are they the only transportation? Is there one vehicle for the whole family? So we have had times where someone comes in and says, hey, I think I'm symptomatic. And we're saying, okay, well, do you have these symptoms? Yes, you need, before we had testing, then you need to go to the testing site and receive testing. The other 5 people in the car also do too, and you now all need to quarantine and go through that process. And that's really difficult because it's, well, no, but my husband brought me here and he has to go to work, but he's been exposed, and kind of explaining that has been difficult. And we understand the barrier that the patient has, but at the same time, we're desperately trying to look at that population health piece too.
We have another question about where the next free clinic is. And I would add to that, what is the scope of geographical scope that the free clinic serves?
So free clinics are throughout the state of Virginia. Our clinic serves Harrisonburg and Rockingham. The clinic in Augusta closed their doors for primary care, kind of just as the pandemic was coming underway, but they do offer dental care. And then we have Shenandoah above us, and then Luray have free clinics there as well. And then there's a clinic in Greene and Orange and Charlottesville, and then throughout Winchester. So there's coverage depending on each of the free clinics that have been established in their jurisdiction, what they cover. And it's based on the bylaws and what that community determines. So we don't have like districts like the health department does. We're determined based on who established the free clinic in that area. The other part of that is you're saying like kind of like where they're going?
Yeah.
Okay. Everyone's asking that question in the free clinic world right now. So I just recently had a conversation with a couple of other executive directors in the Central Virginia area, kind of Orange, Green, Charlottesville, and I was saying, what are you guys thinking? And I can tell you what we're brainstorming, because that's pretty much where we are right now. So statewide, free clinics are brainstorming, do we, instead of having small entities, do we try to merge those and become one health district? So would it make sense for Charlottesville and Green to come together and try to provide care in those two locations instead of having two separate staff for both of them? I kind of talked with Augusta about that at one point in time. And we've talked a little bit with Shenandoah, and I've said, what are you guys thinking? And they're really focused in trying to do behavioral health, and their area is behavioral health in the schools for children. So they have a different kind of mandate than we do. We've talked at the board level saying, what are the other free clinics doing? We saw a lot of free clinics in certain areas become rural health centers. So a rural health center is a federal designation, and you have to meet certain criteria in order to be an RHC. We wouldn't be an RHC in Harrisonburg because we're a city. But if we set something up in Rockingham County, there's potential for that. I know we've talked and brainstormed about mobile clinics. What do mobile health clinics look like? There's a great example of a mobile health clinic down in Withville, Danville area of Southwest Virginia, and they've done some amazing work, and they're a free clinic, but they're a mobile clinic. So we've looked at that a little bit. And then the other has been to say, essentially what board level we keep talking about at the free clinic is, how do we maintain the access to the services at an equitable level to meet demand? Because right now the demand is greater than our ability to meet, which I think it's always going to be, but we have to look at where our margin is in that and say, how do we uncomplicate healthcare navigation in our community? Is there an entry point? You know, right now at the free clinic, we're saying, let's be the entry point to healthcare in our community. That means if someone comes in our door and says, I don't know if I can have Medicaid or Medicare or anything on the marketplace, I just know I'm sick and I don't feel good. And we can say, all right, well, let's figure it out. Let's see where we can send you. It doesn't always have to be that they have to become our patient in order for us to talk to them. It's, well, if you can, then we're going to take you on and we're going to do what we can. And if not, we want to send you in a different direction. So kind of having those conversations and then saying, who can we collaborate with to kind of expand and be able to meet those demands ongoing? And right now, the hardest thing is providers, is that internal staff infrastructure, and that we've been hurt the most in our volunteer, understandably so, in the middle of this. And a lot of volunteers that are currently working in the healthcare industry can't cross, kind of contaminate themselves. If they're going to be in a healthcare unit at the hospital or working, they can't then come volunteer on Wednesday mornings for us, because they're exposed to a whole different group of people that could then come back and hurt what they're doing at the hospital. So there's a lot of exciting brainstorming going on. I will say that this is a very engaged board. We started meeting every month and having regular conversations about what does this look like for us long term. And essentially what it keeps coming back down to is, how do we as a board make sure we are providing the ability for that access to the healthcare, and what our role is in that moving forward.
That's exceedingly helpful information, Summer. Thank you so much. I'm cognizant of the time, so I want to touch on this strategic question that one of our Rotarians raised. And I think it builds into some of the brainstorming that you've been doing with your board, as well as with other free clinics in our area. and that is, where do you see the free clinic in the next 1 to 3 years? Post-COVID, perhaps, but learning the lessons of COVID from a strategic standpoint.
I see that we focus on 3 things. 1, making sure that we have the ability to provide care. And then the other being what that care is. I want it to be primary care, behavioral health, and dental. And then the third part being who and how do we do that? So who do we do that with? Because we're not strong enough to do it completely on our own. And then how? How do we do that with that other entity or with that other partnership? And that can, you know, and that's really essentially what we're digging into right now, is what does that look like? The free clinic has this amazing building, and not, you know, you heard me say we're doing Monday, Wednesday morning, Wednesday evening, and Friday mornings right now. That's a reduced schedule. I would love to see this building provide 40-hour a week primary care services, level 1, you know, level 2, let's move that into behavioral health, and level 3, we know that dental is a big issue. But I would start with primary care and behavioral health and then build into the other. So that's my dream as the executive director. It's my dream as a individual and a person who has worked with families that struggle to get access into care. And I think that we're in a position now as a board that is dedicated to figuring those pieces out and willing to look at greater community need and the role that we play in kind of connecting those pieces in healthcare, or connecting those gaps in some of the services in our community. We've got so many rich and diverse programs here. And I know, I'm sure you've had a presentation from United Way, even on the Unite Us platform, and in the disability community, they're attempting to do kind of that same thing in another program. And the navigation is the hardest part. You know, and I always say, if you were diagnosed today with something that you needed to see a specialist for, or that you needed ongoing routine care for, would you even know how to go about setting up that care for yourself, establishing how your family would respond and react to it, what the new costs would be? You know, a patient comes in and learns recently they've been diagnosed with cancer, or that they are positive for HIV, how that completely changes their life. And a lot of our patients are already on rocky ground. So navigating them through is such a huge component to the healthcare that we offer here at the free clinic, that's the last piece I would say I would like to grow, but it's also the first piece I'd like to grow, because I feel like they're kind of all hand in hand. That's where I envision us going, and the route we're still fleshing out.
Well, thank you, Summer, for leading this extraordinarily critical service in our community, and for wrestling with those questions on access, availability, affordability, and how we overcome barriers for the most vulnerable in our population. So thank you so much on behalf of Rotary for presenting to us today. If you or Alyssa have any final comments, we have about 3 minutes or so. But that's the end of the questions that have come through.
If anybody has any follow-up questions, they want to reach out to me, please feel free to. I'm pretty open and available, and if you just give me a call, even, we can chat. Someone's shaking their, yes.
George Hirschman here. Just it's a curiosity question. Very, very good presentation today. I greatly appreciate it. How long have you been the executive director?
I started in 2018, right before Medicaid expanded, so March of 2018.
Okay, just curious, that's all. Thank you.
Sure. So if you have follow-up, please reach out, let me know, and we'll make sure and stay in touch and kind of share with you guys. We're fleshing out and figuring out what our next steps are.
Mhm.
Wonderful. Thanks so much.
Thank you, guys.
Excellent job, Summer. Thank you so much for the presentation and for being here today. And Elisa for the great introduction, and Braden for coordinating today's effort. Thank you all Rotarians for joining us today for a great meeting. Any guests that may have come in or out, we appreciate you joining us. Look forward to seeing everyone next Monday at 12 o'clock. Everyone have a great week.
Thank you.